certainly there's a lot of time now, and you may have heard this from others, working on the electronic health record system, a lot of time documenting, going through things, a lot of bureaucracy that we have to often deal with that.
Hello and welcome to eShadowing. It is Tuesday. It is time to hang out today with another physician sharing their specialty. Today with us, we have an electrophysiologist, which is a really cool name and a cool specialty, Dr. Gregory Marcus. Let me find him in the list. Dr. Marcus, if you are here, I see you. Let me see if I can catch it as all these people are joining. Raise your hand, Dr. Marcus, if you can, so I can. This is Zoom participant windows jumping all around as people join. Where'd you go? To remember my alphabet. A, B, C, D. Oh, there you are. Got it. Boom. Promote to panelist. All right. Welcome, Dr. Gregory Marcus. How you doing?
Good. How are you?
I'm wonderful. What is that beautiful backdrop behind you?
So it's virtual, but it is what I'm looking at right now. This is the view from my office, and today, thankfully, is a beautiful day like this. Not raining for once.
Nice.
But yeah, you can see a little bit of the Golden Gate Bridge there, some of the San Francisco Bay.
Beautiful.
That's my view.
What a wonderful, wonderful view. We're going to talk about some electrophysiology today. How's that sound?
Sounds good.
All right. I assume you like talking about that since you chose a career in cardiac electrophysiology. What led you down that path to begin with?
Well, it was a multi-step iterative process. Coming out of medical school, I thought I wanted to do, excuse me, either general internal medicine or cardiology, having had very good experiences in both in rotations in medical school. But very quickly, as an intern in internal medicine, was very excited by cardiology for a number of reasons. One, it is so evidence-based. There's perhaps more data and more of the things that we do in medicine based on high levels of evidence, randomized controlled trials than in any other discipline. Two, there's very interesting physiology, so a lot to deduce. It's much less about memorizing long lists of names of things and much more about understanding things and thinking about them and kind of puzzle solving. And then three, there are many definitive therapies. So you can literally save a life. There are also interventions that can substantially help quality of life. And then I realized within cardiology, and incidentally, one of my concerns about going into cardiology was, well, do I really want to spend the rest of my life focused on this one little organ as opposed to all of medicine? And then so it's kind of ironic with that perspective that I ended up in a subspecialty within cardiology, which is just focused on the electrical properties of the heart.
Yep. But
what I've come to realize is if I studied all day, every day, there's no way I could master all the knowledge that there is out there, even in the electrical properties of the heart and the various diseases that can occur, the various ways to address them. And it's very gratifying to have some expertise. Of course, I don't claim to know everything about anything, but to feel fairly comfortable that, you know, I can wield the knowledge that is generally available and so help my patients as best I can, given the knowledge that's out there about electrophysiology. And that particular field of cardiology, in my view, it was kind of an amplification of all the stuff that attracted me to general cardiology. So specifically, in a way, it's very cerebral. We had a conference this morning. We have it every Tuesday morning where we debate and go through tracings and argue and teach and learn a purely intellectual exercise, but that is coupled with very surgical intervention. So cardiac electrophysiology is perhaps the most surgical of the subspecialties within internal medicine. So we put in pacemakers and defibrillators. The case I hope to share with you involves pacemaker, but we also do catheter ablations. We do a number of procedures where in many cases we can cure the patient. We can tell the patient this fast rhythm is gone. It's never coming back.
Mm-hmm.
Other times we can put in these devices that can be life-saving. So that's a long answer to your short question.
I love it. I love it. I'm wondering, one of the leading theories for this football player who had a cardiac arrest on the field is commotio cordis. I'm assuming an electrophysiology problem with the heart. How much did the field go, oh, this is kind of cool? I mean, it stinks for him, but it's bringing to light this thing in our field, and we have the opportunity to talk about it, to bring light to it, to educate about CPR, AEDs, all these things.
Yeah, exactly. Again, I wouldn't use the word tragic in him, since thankfully he survived and apparently he's doing well. So that's great, but obviously be better, all things considered, if it hadn't happened. But yes, it does bring to light a number of issues. So one, the importance of CPR, the importance of delivering a shock, especially if someone has this dangerously fast rhythm called ventricular fibrillation or ventricular tachycardia. And unfortunately, even though it's not the most common thing in the world, it can happen. And it has many causes, most commonly not due to commotio cordis. The good news is there are really helpful things that bystanders can do, primarily calling 911. Now these AEDs, or automatic external defibrillators, are fairly, not totally ubiquitous, but they are around, especially in fairly crowded places. And they work very well for these sorts of rhythms and are designed to be easy to use. So people shouldn't be fearful that, well, I don't want to get a AED. I don't know how to set that up. Don't worry about that. Just open it up, follow the instructions, and trust you could figure it out. I have used this opportunity to try to express the way I was taught about this. If you're ever in a situation where you see someone collapse, they're unconscious, ideally you check their pulse, make sure they're in fact not, they don't have a pulse. Should that occur, you point at someone and say, call 911, point at someone else, go find an AED, and then you start CPR. So I think it is a good kind of circumstance that highlights the importance of that. And then there's a lot of interesting stuff about electrophysiology and how the heart works, and how could that happen to a young, healthy person. And interestingly, when we seek to induce ventricular fibrillation, which sometimes we do, we essentially deploy something similar. So for example, in people at risk of dying suddenly, spontaneously from such a rhythm, the best way to mitigate that or prevent that is to put in essentially an implantable cardioverter defibrillator. Those devices have a lead that we put usually into the right lower chamber, the right ventricle, which will sense, it's always looking at that patient's heart rhythm. And we tell it through a little computer that sits under their skin, if Mr. Jones's heart rate exceeds, and we can program in whatever we want, something like 220 beats per minute for more than whatever we want, 10 seconds, give him a shock. And those defibrillators, or ICDs, are life-saving. Now, sometimes we want to, after we put it in, we want to make sure it works. And in fact, this was the norm when I was initially training, so that you would need to induce or bring about this lethal rhythm to make sure the device can detect it and shock it out. One way to do that is you deliver a little electrical shock through that lead right at a certain part of the cardiac cycle. That part of the cardiac cycle is the same part where we assume Damar Hamlin was struck in his chest, and that's when it's known that to be vulnerable. to such a perturbation to get that ventricular fibrillation going. And I will tell you that as a fellow, so in training, after residency, when you're putting in those defibrillators, and we used to do this DFT testing, we call it defibrillation threshold testing. You do induced ventricular fibrillation, and you'd be sitting there thinking, wow, this is really cool. And then when you're the attending, you have a fellow with you, you're training, and you induce the ventricular fibrillation, you're like, you're panicking. You're like, oh man, I hope this works.
Yeah.
It's a real, an interesting psychological transition in training.
Let's talk about the training path. Cardiology is not known to be the shortest path to a career. 4 years med school, 3 years internal medicine. What does the rest of that training path look like?
Yeah, so usually 3 years internal medicine. I did an extra year as a chief resident, so it was 4 years for me in a sense, although that fourth year in that case is really very fun and you're mainly teaching and doing administration. Then there is a cardiology fellowship that is a minimum of 3 years. That's for general cardiology training. And then cardiac electrophysiology is yet another fellowship that is 2 years. Sometimes those 2 years can overlap with the third year, but it's either 4 to 5 years if you combine the general cardiology and cardiac electrophysiology. It's important to emphasize those, especially for those that are thinking about this, that, as you mentioned, a lot of people view that as, boy, that's a really long time. But you're not sitting in a classroom taking notes. You are doing these things. And so being a general cardiology fellow, being a cardiac electrophysiology fellow is fascinating and exciting. You are doing these procedures all day, every day. You are on the ground. You're working with patients. You're on the wards. You're in the what we call the EP lab, doing the catheter ablations, putting in the pacemakers, constantly learning. So it's a lot of fun. And when you come out, you're a real expert in this field.
Yeah. What do you like the most about it?
It's really not just one thing, but a combination of things. And I should mention that I've also spent a fair amount of my time doing research, which has become more and more gratifying and more of a focus for me. But I love that combination of the intellectual exercise, the collegiality and collaboration with my colleagues and with the fellows, plus the ability to provide our patients with really definitive therapies. The other big part of it for me as a clinical investigator is to be able to discover new things. That's also something that is a very collaborative enterprise, something that's shared, something that's done alongside mentees, other investigators. And then a really fun part of that is being able to disseminate that new information, to present it, to publish papers, to interact with people really around the globe and learn from one another.
Yeah. Did you ever have a point in your career where you thought potentially community-based cardiology was your future, or were you always interested in the teaching, the research aspect where being in an academic center made more sense?
I did consider it. I interviewed at one job that was more of a community-based cardiac electrophysiology practice and could understand the draw to that, but was generally always very interested in training and research and had always hoped I would be able to stay at an academic center.
Yeah. What do you like the least?
Again, not just one thing. Certainly there's a lot of time now, and you may have heard this from others, working on the electronic health record system, a lot of time documenting, going through things, a lot of bureaucracy that we have to often deal with that. And it's hard to kind of thread that needle to figure out how to make the best use of your time given your training versus how to delegate to others, how to find the resources to delegate appropriately. But the electronic health record has been a major advance. I think for patient care, it is better because we have so much information immediately at hand. It is easier to communicate with patients, but the burden of time that needs to be spent there, of documentation is quite large. And then there's been a growing just bureaucracy in terms of various regulations that there's repeated trainings for things and regulations on things that can become somewhat burdensome.
Yeah. I'd be interested to know if there's research or kind of coming down the path for future AEDs for someone listening, watching right now, hasn't seen an AED for some reason, right? It's kind of a biggish lunchbox that's just hanging on a wall. Do you think we'll get to a point where batteries are strong enough, the technology is there, where everyone just has one in their glove box and it's just like one big patch that goes over their chest and does what it needs to do?
Well, it's very interesting. I mean, you bring up this common conundrum between something that works really well for a rare circumstance and how to apply it to large populations, where then that brings in the issue of false positive detections and reactions. So, and the Apple Watch is a great example of this in detecting.
my watch told me I'm having a heart attack. What's going on?
Right. So the healthier and the larger the population you apply any diagnostic test to, any therapy to, the more false positives, especially if they're low risk, you're going to generate. Now, you could argue, and it would be a good argument, that, well, maybe machine learning and artificial intelligence will help us with that and will really help reduce false positives, and that is a promise or a theoretically a capability of machine learning and artificial intelligence. These shocks that one gets, whether it's from the internal defibrillator we place or an AED, are painful. So you want to make sure as best you can that those are only being delivered to people who really truly need it. It's certainly an interesting idea. We actually have a patent, a colleague of mine and I, the patent belongs to UCSF, but because we're faculty, we're the inventors, where the idea is to infer hemodynamic collapse, sudden death from a smartwatch signal, with the idea that then the smartwatch could send a message to rescuers to come give you a shock. And perhaps that could be a feedback loop with a easily, accessible, portable defibrillator.
Yeah. I'm a huge technology nerd, so I think technology is the solution to everything. Like, I almost picture like sleeping with a patch on just in case. Like, I don't want to die in my sleep. Why? I can wear an AED to bed if it's comfortable, and we have flexible circuitry in the future, which we already do. So it's exciting stuff. I know you have a case to share. You want to go ahead and share that?
Yep. All right, you can see that okay, a case of syncope.
Yep.
So syncope is the same as fainting or passing out, and this also circles back a little bit to Damar Hamlin in that it's a fairly common phenomenon, but the cause can range from completely benign, which fortunately is the most common cause, truly in the majority of cases, is not anything to worry about, and is, again, can happen commonly, to the other extreme of it is a sign that this person is going to die suddenly and you better do something quickly. And so we spend a lot of time when we see a patient with syncope thinking about those things, considering those things. Now, in this case, this woman was referred to me. She was quite healthy, 74-year-old. She was just walking up a hill and suddenly lost consciousness. She said she felt normal prior to that. She remembered striking her head against the pavement, and she's otherwise quite active. Now, when it comes to thinking about causes of passing out, one common branch point or one way to categorize things broadly is to think about functional effects, so things that are dynamic, reversible, and those tend to involve the relationship between the nervous system and the heart, versus things that are more structural in the heart, such as an electrical block or an electrically fast rhythm. In the former case, the dynamic, mediated by the nervous system sort of things, those tend to be quite benign. And in fact, they can be a sign of health, because it's healthy to have a robust connection between your nervous system and your heart. Whereas more of the structural stuff, if it's a pure electrical issue, that tends to be or can be more dangerous. So I thought it would be useful to perhaps review the normal anatomy and physiology. Do you see my cursor here? Okay, on the slide?
Do not.
You do not. Okay. That's
Oh,
okay.
yeah, there it is. Yeah.
Oh, now you can see it?
Yep.
Okay,
Yep.
very good. So just to go through kind of a normal heartbeat. So remember, these are the top chambers called the atria, the right atrium here and the left atrium here. They pump blood to the lower chambers, the right ventricle and the left ventricle. This is, of course, sliced open. The ventricles, and really it's the left ventricle, are what generates the pulse. The atria pump a little bit of blood into the ventricles. They help facilitate the flow, but it's the ventricles that pump blood to the body. The right ventricle pumps blood to the lungs. The left ventricle pumps blood really to the rest of the body. The electrical signal starts in the structure in the upper part of the right atrium called the sinus node. So that fires about 60 times per minute. It is innervated by nerves. And these nerves, they come in two varieties. There are those brought by what is called the sympathetic nervous system, that can be thought of as the fight or flight or adrenaline side. The others come from what's called the parasympathetic nervous system. That nerve is called the vagus nerve. So we talk about vagal tone. There are also circulating, what we call catecholamines, adrenaline, that are released directly from the adrenal gland. So if sympathetic tone is turned up, so that would be you're watching an exciting movie, or you're a caveman and confronting a saber-toothed tiger is the classic example, or you're playing a sport, then you'll have more adrenaline effect, more sympathetic tone, and the sinus node will go faster. When you are very relaxed, when you're asleep, oftentimes after a big meal, you'll have more parasympathetic or vagal tone on the sinus node, and your heart rate will slow down. Okay, so this essentially fires, meaning it depolarizes electrically, and then that signal spreads throughout the atria. So the muscle cells of the atria, they're all electrically connected. So that spreads out in a generally very organized fashion. Now, the atria are not generally electrically connected to the lower chambers, these ventricles, because you have heart valves here in the way. They don't conduct electricity. So in the majority of cases in normal physiology, the only way for this electrical signal that starts in the upper chamber to get to the lower chambers is through this structure called the AV node. And then that AV node gives rise to this special conduction tissue called the bundle of His. There was actually a Dr. His who did these initial dissections and described this. That then branches into what's called the left bundle branch, shown here in yellow, and that goes, kind of permeates through the left ventricle, this thick muscle here, and the right bundle branch that permeates through the right ventricle. That rapidly conducts the electrical signal to both ventricles, and wherever that electrical signal goes, whether it's the atria or the ventricle, the muscles squeeze. And so you get this beautifully orchestrated, organized contraction where the atria squeeze and then the ventricles squeeze. Now, the AV node is specialized tissue like the SA node and is also responsive to circulating adrenaline and other hormones like that, as well as is innervated. So it will similarly respond, speed up or slow down, depending on sympathetic tone or vagal tone. So when we see someone that's passed out, the most common cause by far, which is also benign in general, is something called vasovagal syncope. Syncope meaning passing out. Vaso, like the blood, the vasculature. Vagal, referring to that vagus nerve I mentioned. And what's thought to happen in that circumstance is there's just a surge of essentially too much vagal tone. And that can have several effects. Mainly, it can slow the heart way down. You can even get an electrical block between the upper and lower chambers if you really slow down the AV node. It also, incidentally, can cause vasodilation, so the blood vessels can vasodilate. All of those things will reduce the blood pressure. Now, when we think about blood flow to the brain, that relies on a certain amount of pressure that is generated by the combination of the heart pumping at a certain rate and the blood vessels having some tone to them, some constriction to them. So if one loses their vascular tone, the blood vessels suddenly dilate, and or the heart rate really slows down or stops temporarily, gravity will pull blood down and one will pass out. Now, the alternative, there are several, and we don't have time to get into every possibility. One other alternative is there's a very fast rhythm, a fast circuit, for example. So Damar Hamlin, that was an extraordinarily fast and chaotic rhythm in the lower chambers called the ventricles. Those are called tachyarrhythmias, tachy meaning fast. For the purposes of this discussion, just in hopes of keeping it somewhat focused, because we could, I could talk all day about this. If we think just about bradycardia, which means heart going too slow, or heart, it doesn't even mean too slow, it just means slow. There's no judgment to it. It's not good or bad. It's just bradycardia, slow heart rate. So the possibilities there are vagal tone. The other is there's something structural going on, such as an electrical block. And when I say block in this circumstance, I don't mean like a blocked pipe, like we talk about when someone has a heart attack. There's a blocked blood flow. There's actually a blood vessel that's carrying oxygen-rich blood to the heart that gets obstructed. In this case, I mean the electrical signal is blocked. And usually, the great majority of the time, that's because there's a buildup of scar tissue that seems to be prone to have a propensity to form in the conduction system. We still don't completely understand that. That's an active area of research. We know it can certainly happen in human people. Now, if you have such a block, there's no way to fix it except to put in a pacemaker, which I will talk about later. If this was a vagal event, the reason she fell was because suddenly she had more vagal tone, there's no need for a pacemaker there. That is reversible. It's not a sign that her heart's going to stop and never come back. If it's an electrical block, a structural kind of fibrosis, which commonly can occur here, can occur anywhere along this specialized conduction system, then there's a risk that her heart could go into what is called complete heart block, which can make her pass out and really injure herself and even could result in death. So this is a question that we are thinking about when we see someone who passes out. And how do we know the difference? The main way we can distinguish these two, and in fact, the most important, quote, test in this circumstance is by the history. So classically, it's not perfect, but when one has a vasovagal event, the more functional, benign form of passing out, usually there are other symptoms associated with it. So a person will start to feel a little faint. They will sometimes feel a little queasy, nauseated beforehand. Oftentimes there's a trigger. When someone faints at the sight of blood, that is vasovagal syncope. Someone's been standing in the hot sun and they're dehydrated. That's vasovagal syncope. When one just suddenly passes out without warning, they don't have any of those symptoms. That's usually more concerning. We also look at their electrocardiogram, which I will describe in a moment. So in her case, her history favored something other than vasovagal syncope because she was in the process of exerting herself. She didn't have other symptoms. She just suddenly fell. Now, in order to describe what happened to her and the way we evaluated her and ultimately decided to treat her, it's important to talk about the electrocardiogram, which is an extraordinarily common procedure or common test that's done. And in fact, Apple Watches, as well as there are other devices, AliveCore cardiomobile devices, can enable one to record their own single lead electrocardiogram. So just to go through some real basics here in the hopes of helping to illustrate her particular case. So an electrocardiogram, one has electrodes placed on their chest and it records a signal as shown here. And I will point out that the depolarization or the electrical activation of the atria results in these deflections that are called P waves. So when we see these P waves, they're kind of a little rounded and they take a little while. That tells us there's atrial electrical activity. And in fact, when we see organized and regular atrial electrical activity, that suggests normal sinus rhythm. Then, incidentally, the AV node I described in this little bundle of hiss I told you about, those are so small and generate so little activity, they don't really result in any sort of deflection in the electrical signal. You don't see them. You only see a change in these signals when there's meat being electrically activated, when there's cardiomyocytes or cardiac muscle generating voltage. So as this signal rapidly goes down the left bundle branch and right bundle branch, you get this bigger and sharper deflection. It's sharper because it's rapid conduction. It's happening very fast. And it's bigger than the P wave because we're talking about more muscle in the ventricles. And this is called a QRS complex. So you get P QRS. Incidentally, where this dashed arrow is, this is called the T wave. And that is actually the electrical recovery of the lower chambers of the ventricle. So you get P QRST. And just to again bring it back to the commotio cordis example, the time that the heart is vulnerable to going into ventricular fibrillation with either an electrical shock or a strike to the chest is a very small window of 10 to 20 milliseconds at the beginning of the T wave. And the reason that happens is you imagine that, right? So as I said, so the QRS, you have depolarization, electrical activation of the lower chambers. The T wave is repolarization, reactivation. If you're at the beginning of the T wave, that means some of the ventricle has repolarized, but other parts of the ventricle have not. So those other parts cannot yet conduct electricity until they repolarize again. So if you get a little electrical activation in the ventricle right at the wrong time, there's just enough that can electrically activate just a part of it, but the surrounding tissue remains refractory. So you get this meandering, rapid, chaotic wavefront that then perpetuates itself because wherever it goes and depolarizes, it leaves a repolarization wake. And so it kind of self-perpetuates, and that's what leads to ventricular fibrillation. So anyways, coming back to this, so this is a normal sinus rhythm, electrically normal heart, P wave QRS. So in this case, this patient was very nervous, and I did offer what we call a invasive electrophysiology study, which I will describe because she did ultimately undergo that procedure with some convincing. And an intermediate step is to have her do an exercise stress test. And the reason to do that in her case is that with exercise, we expect her to raise her heart rate because she's going to get more sympathetic tone, more adrenaline. If she has a propensity to have more vagal tone and a reversible block, that should not occur with exercise because by definition, pretty much, with exercise, you're going to have more sympathetic tone. So her conduction should be fine with exercise. On the other hand, if there's an electrical block or a fibrosis, a structural block, I should say, as you speed up the top chambers, the atria, that this His-Purkinje system, this His, bundle of His and bundle branches will have more difficulty transmitting that signal. And in fact, that's what we saw. So here's her exercise stress test. These are different, what we call different leads So each lead is like one of those electrodes representing a different vector of the direction of the impulse. But if we look, for example, here, you see P wave, no QRS. P wave, there's actually a delay, a different QRS. P wave, no QRS, P wave, no QRS, and then conduction returns. So this is happening with exercise. So doesn't seem to be related to more vagal tone, but this is more sympathetic tone. So this is not good. This is AV block. You could see this, and it could be benign. There are certain patterns that we don't see here that would be indicative of more of a vagal effect. This fits mostly with an electrical problem. She remained reluctant, though, to get a pacemaker. I told her, you know, given just this and the fact that you passed out, I think you probably should get a pacemaker. And we talked about what that implies. She was still nervous about it. And so I told her, well, there's one other way we can get the most definitive evidence, and that is to do a electrophysiology study. So in this case, we put in catheters. We put one here, and just to orient everyone again, right atrium, left atrium, the top chambers, right ventricle, left ventricle, the bottom chambers. We put a catheter in the right ventricle, a catheter in the right atrium, a catheter. This one won't be relevant to this particular case. We didn't do this in her case, but sometimes we put a catheter in this vein that wraps outside the vein called the coronary sinus. And then a catheter that can record that bundle of His. I told you that it doesn't generate enough electricity to result in a deflection in voltage on the surface EKG, but if you're able to get a catheter right over it, you can see a little deflection. So at the very top here is that same EKG. The paper speed, or how fast we record it, is faster than a normal EKG. So everything's kind of spread out, but hopefully people can appreciate there's a little deflection there. That's the P wave. And of course, this is one beat, and we're seeing it in real time over and over again. This is the QRS. This HRA stands for high right atrium. So this catheter that's in the atrium is only recording signals when the atrium is electrically activated. You see that kind of lines up with the P wave. This ventricle, RVA, stands for right ventricular apex. And you see there's an electrical signal there. That it's only electrically activated when the ventricle is activated. And then this HBE is where the His is. And so this is straddling the valve between the right atrium and right ventricle. So you see an atrial signal. You see this signal here representing the bundle of His activation. And you see the ventricular signal. This distance or this kind of isoelectric line between the atria and the His, that generally represents AV nodal conduction. You can't record, or in a normal electrophysiology study, you don't see AV nodal conduction, you infer it. But if the block is at the level of the AV node, that implies more of a vagal thing. So if you see an A without a His, that's more of a functional AV nodal issue. However, if there's a structural block, you are more likely to see an A, then a His, and no V, at least at times. And that's what we found in her case. Here we have this patient's electrocardiogram. So the EKG, again, this is the same EKG we saw before, but faster paper speed. So everything's spread out a little bit, but hopefully you can see P wave, QRS, P wave, QRS. These signals, these are in the right atrium. So you only see the signal during atrial activity. And hopefully I can convince people there is a P wave here. You'll notice there's P wave, QRS, P wave block. This is very similar to what we saw with the stress test. I think her disease has progressed. So this is now happening at rest. Here's the right ventricular signal. Unfortunately, there's a little bit of noise here, and I recognize that might be a little confusing, but hopefully you can trust me. This is kind of the right ventricular signal lining up with the QRS because the ventricles are being activated. There's no signal here. Again, a little bit of noise, and right ventricular signal again. And then a little bit more subtle, here is the A H for bundle of His, V. And I realize this bundle of His is very small. And so, oops, oh yeah, those moved. Dang it. Let me get rid of those. So I'll just point with my arrow. You see this little bundle of His here. So there's a and a His, but no V. So this level of block is at the level below the His. So this is very consistent with a structural problem, not a vagal or dynamic problem. And then when we pace, now through those catheters, we can record the signal, and then we can also electrically activate wherever they touch. So here, we're pacing the atrium. So we're speeding things up a little bit to see what happens. Does it get better or worse, this block? And we see the block actually gets worse. So now when we pace the atrium, we have A, atrium, His, ventricle, pace, atrium, His, nothing, pace, atrium, His, nothing. So now we have 2 beats in a row that didn't conduct. That's further evidence that this is a structural problem that's getting worse, and it's likely to progress. So the treatment for this is to place a pacemaker. And putting in a pacemaker is actually pretty straightforward. It's something that can take about an hour and a half. Usually, you could theoretically send most patients home the same day. We tend to keep people overnight, and they go home the next morning. We make a little incision, usually near the shoulder, just in the skin. We make a little pocket under the skin, excuse me. And then we place these leads into the heart by accessing a vein. So we don't need to open the chest. We don't need to open the heart. We can access this vein. It's kind of like putting in a big IV. You guys may have talked about this before, but you get in there with a needle, you take the syringe off, you put a little floppy wire through that needle, you take the needle out. Now you have a wire in the vein coming from outside, and then you put a little plastic tube that we call a sheath over that wire. You take the wire out, that sheath has a one-way valve on it, so no blood can come back, but you can put stuff inside. So now you have that sheath there. You put your lead inside the heart, usually under X-ray guidance. We have a little stylet that fits inside this lead, so we can make that stiff and shape it however we want. Usually we put one lead in the right ventricle and one lead in the right atrium. The reason they go on the right side of the heart is because that's where the veins go. And then there are a couple of ways to fixate it. The most common is there's a little screw you can deploy at the very end. You apply a wrench to this side of the lead and turn it, and it will deploy this little screw. You then take that stylet out, you break the sheath. The sheath is a kind of a breakaway, kind of tearaway sort of thing. Then you attach it to this pulse generator, which is the battery and computer for the pacemaker, and then tuck that into that little pocket under the skin you've made and sew it up. Very straightforward. And then I wanted to just mention a couple of things just to demonstrate how all this stuff is, how we're always learning and how this is always constantly in evolution. So one relatively recent advance has been what's called a leadless pacemaker, where you can place what is essentially kind of like a bullet-sized thing that is both the lead and the computer all together. There are advantages and disadvantages to this, but this is becoming more common. One of the concerns here is that this pulse generator can get infected. People need to have generator changes over time, and if so, then sometimes you need to take the whole system out, which is not so easy with the leads. Now, the other thing that's been very interesting that we've learned over just the past maybe 10 years is that when people are paced frequently from the right ventricle, and remember, these are generally people, if they're going to be paced in the right ventricle, they generally have a block here, as I described, as in our patient. Now, the most common reason we put in a pacemaker is because of sinus node problems. So sometimes you just pace the atrium and the AV node and his Purkinje system are fine. But in cases where there's a block between the atria and the ventricle, they're going to be pacing in the ventricle frequently. Pacing here activates the heart electrically in a very different way than how evolution set things up. You're no longer going through the bundle branches. You're starting here in the apex of the right ventricle and kind of hitting this middle wall and then spreading out from muscle to muscle in a disorganized way. And what we've learned is that in some people who have right ventricular pacing frequently, they can develop a weakening of the left ventricle. They can go into heart failure. We didn't used to know that. We would just see patients, they came in with heart failure. Oh, their heart's weak and dilated. We don't really know why. Okay, we'll try to treat it. But it turned out it was us that was doing that because we were pacing their right ventricle. So there now is a lot of interest in thinking about, well, can we activate especially the left ventricle, which is what, again, generates the pulse to most of the body, in a way that's more physiologic. And the latest approach is to try to capture the left bundle itself. And the way we do that is there are special long sheaths that force your lead over here, and then you screw it way in until you can capture the left bundle. And that's what we did in her case. And I'll show you how these EKGs are different. So again, to reorient folks, this is our normal, non-paced, normal sinus rhythm, normal QRS. On the left here is a patient of mine where we put in a pacemaker maybe 10 years ago. This is the way, and the right ventricular lead was put into the ventricle. And you'll notice these QRS complexes are wider than this one. And the reason is because it's being activated not through the rapid normal conduction system, but from muscle to muscle. It's much slower, and that results in dysynchrony of the left ventricle. So the ventricle's kind of contracting in this kind of sloshy way, first the septum, then the lateral wall, rather than in squeezing in an efficient way. And then here's our most recent patient where we are actually capturing the left bundle, and you can hopefully appreciate this is much more narrow, looks like the normal QRS, but these are actually paced, and you can actually see the little pacing stimulus there. It's a little sharp, tiny deflection. So these are paced, this is a paced ventricle. These are paced QRS complexes, but it's narrow because we've engaged that conduction system.
That's pretty cool.
So she incidentally feels much better, and in retrospect recognizes that she was feeling fatigued, she wasn't feeling well, she wasn't able to do her normal stuff. And now with this pacemaker, she's back to normal and full of energy and doing very well. So I can stop sharing there.
Yeah, that's awesome. I switched cameras to my iPhone, so hopefully you guys can see me now. If you have a question and you want to come on and ask, go ahead and raise your hand. I'll bring you on. You can ask a question. Who is it here? Anu says they're an applicant to medical school. They're a device rep with Medtronic and has actually worked with you and other UCSF EP attendings implanting pacemakers and defibrillators. It sounds like they're wondering your thoughts on whether or not that's a cool pre-med job.
For sure, definitely. Hello, thanks for joining. Yeah, the device reps, and there are several types of device reps, and I'm sure in other specialties there are device reps, really are engaged meaningfully in what we do for our patients because they have very special expertise. I would say that the nature of that is variable, but usually, as Anu knows, those reps are in the room with us and handing us equipment, helping to do programming. Similarly, when we do, and we didn't spend a lot of time on, or we didn't spend any time on catheter ablation procedures where we go in and we buzz certain parts of the heart that can cure or mitigate effects of fast heartbeats, early heartbeats. Similarly, we use these mapping systems that are very sophisticated. We draw three-dimensional maps. We can move them all around. We mark where we burned. We can make movies of the actual circuit based on our mapping. And there are reps that help us with that. And for sure, I think those are fantastic jobs. And I would hope that selection committees recognize the value of such individuals, and certainly is an opportunity to exemplify your understanding of cardiac physiology. And I would also encourage all such folks to ask questions and make sure they're, fully understanding what's going on.
Yeah. Stephen, hello.
Hello, I just had a question about like interdisciplinary fields within cardiology. So how do you, let's say you have a patient that presents with, a variety of cardiac symptoms. How do you decipher whether something's an electrophysiological problem or a structural problem with the muscle? How do you use your skills, or how do you consult with other cardiologists to come up with a diagnosis?
Yeah, great question. And I would say that is part of the art of it, and really part of the practice is recognizing when you see someone with a given symptom, when you have to consider other causes and bring in other individuals. So shortness of breath is a perfect example. So shortness of breath could be a lung problem. It could be a heart problem, but that heart problem could be either because there's insufficient blood flow to the heart. It could be because the heart is too weak. It could be an arrhythmia, so that maybe they're having atrial fibrillation, a fast rhythm in the upper chamber. Maybe they can't, and this is a very common indication for a pacemaker, maybe they have what we call chronotropic incompetence, meaning their sinus node just can't increase the rate when they exercise. And so this is something we're always thinking about. And so we will often order assessments, even such as an echocardiogram to assess the strength of the heart. We will order a stress test to make sure that the blood flow to the heart is okay. And then if we see evidence, oh, it looks like this person actually has coronary artery disease, more of a plumbing problem, then we refer them to, for example, a general cardiologist, or we find, oh yeah, the heart's weak. We refer them to a general cardiologist or a heart failure specialist. We exclude all heart problems, then maybe we refer them to a lung doctor. Usually as a cardiac electrophysiologist, it's the general cardiologist referring to us, but not always. Sometimes we see them first, but a lot of it is very collaborative. Also, a lot of the work we do is in collaboration with another heart specialist. So for example, we get a lot of patients where we are doing various things because they have heart failure. So they've seen a general cardiologist, they know their heart is weak. And there's some cases where we can put in a special sort of pacemaker to help resynchronize their heart that can help their heart failure, or we put in a defibrillator because they're known to be at risk for sudden death, or we do a catheter ablation of frequent early beats that they or we have noticed because that might help treat their heart failure.
Cool. David, hello.
Hello, can you hear me clearly?
Yep.
Great. Three questions, two easy ones and one a little bit longer. What is your lifestyle like working as an EP?
Yeah, so mine is a little different since I do the research, but so one of the things of many that made me decide to do EP was I remember a then fellow when I was a resident who had decided to go into EP, and I was thinking about it, saying there's no such thing as an EP emergency, which is kind of nice. So meaning if you are an interventional cardiologist, meaning you do angioplasties and stents, usually part of that job involves taking call overnight where you could get called in because the time to open that artery is critical for people with heart attacks. In EP, we don't have that equivalent. Now you could say, well, that's not exciting. Or you could say, wow, I know pretty sure I'm going to be able to stay in bed all night. So the emergencies that are relevant to us would be things like someone coming into the emergency room with complete heart block. They need a pacemaker. They're otherwise in dire straits. One can put in what's called a temporary pacemaker fairly easily, where you just float a catheter through a central line. Many ER docs can do that. Most general cardiologists can do that. So that's not necessarily something that requires an electrophysiologist. Another example is someone comes in with shocks from their defibrillator or ventricular tachycardia, ventricular fibrillation. There are usually temporizing steps that maybe could benefit from a phone call from an electrophysiologist, but there isn't anything necessarily emergently to do. So it varies a lot depending on the nature of the practice. Okay. Certainly there are many people in very busy practices, both academic and community, that work crazy hours, but generally it can be crafted to be pretty reasonable. The private practice community practice I mentioned I interviewed with when I was looking at jobs after fellowship, they valued lifestyle, and they just decided, you know, and really the trade-off is with how much revenue you want to bring in. And they just decided they would rather spend more time with their patients, do less procedures. Yes, they would make less money, but they're going to be less stressed and be able to enjoy more of a lifestyle outside of work. But I would say that generally it's pretty reasonable. This is one of the benefits of academic medicine. One of the, again, these are all trade-offs. The downside is maybe you're writing grants or papers on nights and weekends. On the other hand, you also have a lot of flexibility in your time, especially if you are grant funded, which is meant to protect your time. And there, I actually have a whole talk on being productive in research. I make the argument that the work-life balance is much more blended, where number one, getting good sleep, getting exercise helps you in general to be more productive, to have a better sense of morale, to think quicker, to be more creative. And especially in the more creative fields, it's oftentimes when I'm out for a bike ride that I generate the best ideas. So I think, you know, these things fitting together actually makes a lot of sense.
And I'll just put my other two questions to one question. So I'm making an assumption though, that I'm sure it seems like you'll be developing relationships with your patients, not one and done. You're seeing them over a course of their lifetime, evaluating the device that they have placed. And then if you talk a little bit on that. And then the other question is, who can you, in your years of experience, what is the patient population, maybe the socioeconomic, the cultural, like what's the profile of what we're seeing in these last maybe 10 years?
Yeah, these are two actually really fantastic questions because they do hopefully help understand the flavor of this sort of practice, which again, these are other reasons that I was attracted to it. So, and in both cases, there's a wide variety. So unlike in primary care, where pretty much you have a patient, you are with that patient for the long term, pros and cons to that. In EP, it runs the gamut. So there are some people that have a particular type of fast rhythm that is easily, relatively speaking, curable with an ablation. Sometimes I see that person in clinic, we talk about it, they decide to have the procedure, I do the procedure, they're fixed. I usually will see them one more time and then I say, nice knowing you, I don't need to, I'm happy to see you, but I don't need to. You should be cured of this. So there's those groups, that's a group of patients. Then there are patients that you do develop a long-term relationship with. So especially patients with atrial fibrillation, as you alluded to, patients with a device. And so there are many that I have, you know, been seeing for 10, 15 years. I know them really well. In some cases, it's, yep, they're doing well, you know, just to check in. There are others where we're constantly tinkering, where they do well for a few years, and then their AFib comes back and we need to readdress. In terms of the demographics and the types of patients that we see similarly, very broad. So, and again, this is something I enjoy about this. So we see very healthy, young people. Those tend to be the ones with the fast rhythms that we can easily fix. We see people in their 80s and 90s that have passed out or needed a defibrillator or something else. And then similarly, in terms of socioeconomic status, race, ethnicity, it's really pretty much everyone. Here at UCSF, we see the most well-to-do individuals. We also provide cardiac EP for the county, the San Francisco general population. So we see pretty much a huge variety, which again is a great part of the practice.
Well, Dr. Gregory Marcus, thank you so much for coming on eShadowing. Our time, unfortunately, is up. We had close to 100 people at one point learning about cardiac electrophysiology from you today. So thank you for taking some time to share.
My pleasure.
Everyone have a wonderful day. If you missed anything, this will be up on YouTube shortly. Everyone take care. Bye.
Thanks. Bye.